organization about?
Citizens Council for Health Freedom is a nonprofit, so it's located in Minnesota, but it does national policy. And our mission is to protect individual choices, healthcare choices, individualized patient care, and then the right to medical and genetic privacy. And we believe that freedom requires privacy, and that you cannot be free if you're under surveillance or if everybody knows what you and your doctor are doing together and can control it from the outside. So that's why we say medical and genetic privacy rights are so important.
And you've just recently released a book on that. Tell us about it.
Yes. The book is called Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records. And that book, which can be found at bigbrotherintheexamroom.com, really tells the story about how the federal government and Congress have imposed the electronic health record that you see today in the exam room and that you see at the bedside in the hospitals, and really how the electronic health record, or we call it the EHR, how the EHR is not what you think it is. It's not like that handy-dandy tool in your pocket. It's not even technological wizardry. As a matter of fact, it's just very difficult for doctors and patients to use, but not only that, it's really not about patient care. It's about collecting data and reporting data to the government, and it's about controlling medical decisions through the profiling that happens with the collection of that data and the analysis of that data and the profiling of the patient and the doctor. And so I quote one physician I quote lots of physicians, lots of very irate physicians and lots of very unhappy nurses. But in particular, this one physician who is an expert on EHRs and health information technology, he says that the electronic health record is really a command and control system in the exam room that controls the use of resources and controls every medical decision. I'm paraphrasing because I'm not looking at the book right now, but you get the picture that the electronic health record is not there like just a wonderful piece of technology. It's not there for the patient. It's not there for the doctor. It's there for the government and for the third parties who want to use the data to do other things than what the patient and the doctor want it to do.
If our listeners want to know more about Twila Brase, you can find that on our website, pointofview.net. You can click on her picture there. We have a bio up, and we also have a link to information about her book so that you can learn more about it. Twila, in your own background, I believe you were a nurse, were you not?
Yes, and still am. Yes, I worked in a pediatric emergency room, and then did school nursing after that to get better hours. But still, the emergency room is still my favorite. It's very exciting and it's very intense, and it just lets you see so many different situations that happen out in the world medically.
Now, are you still actively engaged in that?
No. I am doing this full-time and beyond, running this organization, which has been around for 25 years. I am the co-founder, along with Martin Kellogg, and we have gone from being here just in Minnesota to doing our work nationally and going to Washington, D.C. And so, no, there's no time to actually be in the hospital or a clinic anymore.
Now, you mentioned the health records issue. This is actually bipartisan, isn't it? I mean, didn't George W. Bush want to move electronic health records towards the later part of his administration?
Yes. So if I were to put it on sort of a timeline, it started with Hillary and her plan. She had a national medical record system in her bill. She had HIPAA in her bill, and then it was a bipartisan
by in her bill, do you mean the Clinton Care bill from back in the 1990s? Right.
That's right. And then a little piece of that called the Administrative Simplification section got created through HIPAA, and everybody's heard of HIPAA, which is the so-called privacy rule. But as I talk about in the book, there's nothing about privacy in it. It's a massive disclosure rule, and so people have been deceived. And then yes, as you said, President Bush did an executive order to start the movement towards a national medical record system. And then when President Obama got in, within the first 4 weeks, he signed a law that mandated the electronic health record unless you were willing to receive penalties for every Medicare patient that you saw.
And if I remember right, that was about $30 billion thrown at the electronic health records, wasn't it?
Yes, and some people say 36 billion, other people say 37. So it's right up there.
It's a lot of money.
It's a lot of money.
It's a lot of money. And, the amazing thing is the whole purpose in this was to be able to sort of create electronic health records so that they could be shared. So if I went to a different doctor, different clinic, different hospital, that information could be spread over there fairly easily, and I didn't have to go through refilling out all the forms every time I went to a new doctor or went back to the old doctor. But every time I go back to a dermatologist, their clinic has changed somehow, and I've got to refill out all those forms.
That's because there's a difference between the stated purpose and the real purpose. So that was the stated purpose, that we were going to have all this convenience and it was going to be effective and efficient, and they'd have the data when you wanted it and when the doctor wanted it. But the fact of the matter is, it was really the entire system is built for collecting and reporting data. And so they took that system and they wrapped patient care around it, which has not been successful. It doesn't follow the way patients are taken care of, the workflow of the doctors and the nurses. It doesn't follow it. And as a matter of fact, lots of things are missed because it doesn't follow it. Because, like let's just say you have a blood test. And you get and the blood test comes back, but it comes back to the electronic health record. And you, the doctor
hold
or
that
the nurse.
thought there, Twila. We're going to come back here and we're going to take a break and come back in just a minute. So stay with us. We'll be back with Twila Brase.
This is Viewpoints with Kirby Anderson.
Sometime in the near future, America will go over the entitlement cliff. That is the argument of Dr. Merrill Matthews, co-author of the book On the Edge, America Faces the Entitlement Cliff. He was on the Point of View radio talk show recently to discuss the problem and possible solutions. The first part of his book explains why entitlement programs fail. To put it simply, they are not actuarially sound. But the problem is even greater than that. He also shows how the cost of entitlement programs always exceeds projections. He details the expansion of Social Security, Medicare, and Medicaid. The second section projects how America will fall off the entitlement cliff. Not only does he provide projections for Social Security, but also for the impending pension crisis, the welfare debacle, and the health care debacle. This is true of both private sector pensions as well as for public sector pensions. He also includes sections on stepping back from the cliff. He deals, for example, with the fact that we have different types of safety nets in society that result in different outcomes. We do have examples in other countries of how to construct a sustainable safety net, and I wish some members of Congress would read the sections on principles of a sustainable safety net and embracing actuarial principles. There are solutions to the financial challenges we face with entitlements, but we also need to elect a Congress, politicians who actually want to solve some of the problems created decades ago with these government programs. So far, most members of Congress, unfortunately, want to ignore the fact that sometime in the future we may go over the entitlement cliff. I'm Kirby Anderson, and that's my point of view.
For a free copy of Kirby's booklet, A Biblical View on Anti-Semitism, go to viewpoints.info/anti-Semitism. Viewpoints.info/anti-Semitism.
You're listening to Point of View, your listener-supported source for truth.
And welcome back. Merrill Matthews with the Institute for Policy Innovation, sitting in for Kirby Anderson. And we have on the phone for this hour Twila Brase, president and co-founder of the Citizens Council for Healthcare Freedom. That's based in St. Paul, Minnesota. And we're talking to Twila about her new book, Big Brother in the Exam Room, which gives us everything we ever wanted to know about the government's efforts to get control of our medical information and use it for nefarious purposes. So, Twila, this is we've talked about this as a bipartisan issue. The government's been involved in this for a while, and President Obama actually expanded that effort, throwing $30 billion, at least $30 billion at it. But now we have this situation where we go in to see the doctor. The doctor can't talk to us because the doctor's got a laptop or an iPad and filling out information there and looking at that and trying to create electronic medical records in order to be able to sort of fulfill all these requirements of the federal government. We're going to talk in a minute about how this applies to Medicare for All, the effort of the government or some Democrats to take over the whole health care system. But it's really interrupted the doctor-patient relationship, it seems to me.
That's right. It has shifted the focus of the exam room from the patient to the computer, and so they're clicking. I can't tell you how many patients have complained to our organization about the fact that all they see is the back of the doctor's head. The doctor doesn't touch them like the doctor used to, doesn't look at them in the eyes, because in order to be paid, this is where their focus has to be, is fulfilling these requirements of the electronic health system. I've heard, I think I quote in the book that one doctor has said something like, he's no longer taking care of the patient, he's taking care of the chart, right? But, I think that patients don't even understand the actual safety dangers. So there's the, frustration that you don't have a doctor that sees you as the ultimate thing that's happening in the exam room, right? But the safety, too. So I was starting to say before the break that you can have something that is ordered and the lab sends it back through the electronic health record system, and then it's up to the nurse and the doctor to remember when they're now on patient 10 instead of patient 2 that they did this order, and they have to go looking for it. As a nurse in the ER, we would take when the results came back, we'd slap it on the front of the chart, and you couldn't miss it, right? There's no way you could miss it. But now you have to think, oh, yeah, that's right, I have to go into the record, and I have to look through the different screens, and I have to find it. And so you can't immediately look at it and see it's good or it's bad. There was a new report that came out that's from Fortune magazine and Kaiser Health News called "Death by 1,000 Clicks: Where Electronic Health Records Went Wrong." And
It's got to be a really long report.
Well, they started out by talking about a 47-year-old attorney in Vermont who was having a headache. She went to the doctor. She went twice, and nothing really happened to her. It never got diagnosed that she had a aneurysm, and so she died. And what her husband found out, was that there had been an order placed, but the order never arrived. And so it never happened. This brain scan that she was supposed to have never happened, apparently. Nobody even told her about it to ask about it, right? And so this is the sort of thing that can be lost in the electronic system, and that's what they're finding. There's all these kind of errors. FDA has admitted several years ago, 2010, I think, they admitted that there had already been 6 deaths and 43 injuries caused by health information technology. And so this is not a surprise, and people should not be surprised, because the mandate said you have to buy these things, learn these things, install them, get all of your staff trained on them in 5 years, or you start losing money from the federal government. And so all of these electronic record companies suddenly popped up out of nowhere to get these $36 billion, right? And they weren't made for patient and doctor care. They were made just to do what the government said they had to do, and that was it. And so they're faulty systems. They're danger-prone systems, and people don't understand that.
So where are we now on electronic health records? Have they found any solutions to this? Is it still just a muddled mess?
It is still a muddled mess, and as a matter of fact, in my book I quote this one an engineer, is a great. He says, I used to think we could improve the electronic health record from within, but now I realize the only way to truly improve electronic health records is to start over. And see, that's the reality, because they were never made for patient care. They were made for billing and booking data and reporting data. They were never made for patient care. And so, the free market could have done this, would have done this. It would have done this over time, and it would have been patient and doctor-centric. So where we are now is that your listeners who are listening to this conversation need to be very cautious. They need to figure out what's in their electronic health record. They need to listen carefully when the nurse says, well, you're taking this medicine, and this medicine, and go, oh, no, that's not me. Actually, people have found a doctor who has said their entire history to them and then looked at the doctor and said, I don't have that diagnosis. I've never been treated for that condition. I've never been hospitalized for that condition. Those are not my medications, right? Somebody else's complete medical information might be in yours. And so at the end of the book, I actually have action steps for Congress, for state legislators, for patients, and for doctors. And patients should get the book and just pick 3. I think I've got 40 different possible ones to pick from. Just pick 3 and start there. And one of the ones that I tell patients they should really start with is to look at the doctor after he has prescribed something or said, we're going to treat you this way. Look at the doctor and say, is that what you think is the best for me, or is that what the computer is telling you is the only thing that you're allowed to do for me? Because it's not just about dangers from the data. It's from the fact that outsiders are populating the electronic health record with certain treatment protocols and not allowing other treatment protocols to be in there, thus limiting what the doctor can do, limiting the doctor's ability to treat you like the patient that you are and need to be treated for. And so that is something that patients should do all the time to protect themselves. Look the doctor in the eye, who's got an ethical obligation to you, and say, is this what you want to do to me, or is this what the computer says you can?
So what's the solution to our health records? I mean, it seems to me that we all, as individuals, we manage our bank accounts, we manage an IRA if you have one. We don't have to share that information with anyone. What is Google and Microsoft have both tried to jump in this area to create, I think one of them did health vaults and some other things, as a way for us to have some way to manage our health record so that we have access to that and then could share it with a physician. What's the solution to this?
Well, the very first solution is for consent requirements to be restored, because HIPAA took them all away. And as soon as consent requirements are restored, the entire system would have to work on the basis of giving you consent to share your information, giving you the right to either deny or give consent to share your information. And then, of course, the only information that would be shared is what you chose to be shared. And it wouldn't be, to all of these outsiders for all of these purposes that HIPAA allows it to be shared without your consent. But I think the other is just the entire mechanics and technology, right? Because they weren't made for patient care. And the mandate has to be removed. Congress needs to remove the mandate. I think there's a lot of doctors that would be okay with electronic health records, but they want them to work for patient care, and then they want them to work for patient sharing as the patient deems necessary. And so, it's like it started with a whole big wrong premise and $36 billion. Well, just because we've put all that money into it doesn't mean that we should continue with this faulty, dangerous system. We have to remove the mandate, remove the penalties, and let the free market decide what kind of electronic health records there's going to be, and let doctors who don't want any part of them go back to paper, which is so inexpensive, so easy to figure out right by just looking at it what's wrong with the patient. Doctors are lost. They're lost in the electronic health record, lots of them. I had one doctor tell me he's just given up looking for the nurse's notes. just given up.
Yeah,
They're too hard to figure out where they are.
Former governor, now Senator Rick Scott from Florida, told me back before he ever ran for governor, he was a healthcare executive, and when he started Solantic there in Florida, he said, we tried to do the electronic health records, didn't work at all, so our doctors just write down their notes and we give them to the nurses and they make a PDF of it, so they actually have a way to scan it and put it in. They have access to it, but they didn't have to go through the whole process that we're doing now. When we come back, we want to talk a little bit about Medicare for All, for one of the reasons that once we put our health care information under the government is going to have access to all of this information and is going to use that, I think, to manage us and to try to control us. So we will be back with Twila Brase in just a minute.
Point of View Radio has been changing lives for a generation. Listeners have been inspired to apply themselves in all kinds of ways, to stand up as lawyers defending the Constitution and freedom, to start Christian schools, training up a new generation, to launch ministries on college campuses, even to run for and serve in Congress. So again, what are you doing to make a positive change? One way to start today is to join the Truth Team, Truth Team 360, and help us change lives. Our nation needs a Truth Team very badly. Support Point of View Radio today at pointofview.net. Set up your monthly gift by clicking the Truth Team 360 picture and then carefully follow the directions. pointofview.net. By phone, you can give at 1-800-347-5151, 800-347-5151, or mail that first donation to Point of View, Box 30, Dallas, Texas 75221, Box 30, Dallas 75221. Point of View will continue after this.
You are listening to Point of View. The opinions expressed on Point of View do not necessarily reflect the views of the management or staff of this station. And now, here again, your guest host for Point of View.
And we're back. Merrill Matthews sitting in for Kirby Anderson, and we're talking health care this hour and next hour. On the phone with me, Twila Brase. She is president and co-founder of the Citizens Council for Healthcare Freedom. That's based in St. Paul, but she works on healthcare issues around the country. Twila has a new book out, Big Brother in the Exam Room, that looks at electronic health records. Twila, we've got the Democrats are all about Medicare for all now. They want to move to a single-payer healthcare system. Medicare for all is actually a misnomer because these plans would actually change Medicare. Seniors on Medicare would no longer receive the Medicare that they're familiar with as we move to a government-run single-payer healthcare system. Twila, I think that's going to be part of the Democratic platform in 2020. I don't think we'll get it before that, but I think that'll be part of their platform and part of their presidential campaign. If we actually move to something like Bernie Sanders' Medicare for All, is all hope of health care privacy and health care freedom gone?
I think so. Yes, because the plan here, of course, is just to have the government run everything. And once you have the government run everything, once they have control of the money, right, then they want to have control of everything, and that means data on the patients, data on the doctors to try and control who gets access to the money, who has an authentic right to the money, whose conditions will be those that will be funded, and whose conditions and at what ages will other things not be funded. I think that has been what has happened in every government system. Sometimes it's, it comes from, all the money comes from the central government, and sometimes it is parsed out like it is in Canada to the different provincial governments, right? But it's still parsed out. And there's still only so much available. And I think some have more control than others using the data. But some it's just the fact that you've got a global pot of money, and then when it's gone. Because I know chiropractors and physicians in Canada who, after they've gone through their pot of money, if that takes 5 months or 7 months, a lot of them come down here to the United States, Florida, Texas, Arizona, and they set up practices until they can go back up to Canada and get another pot of money. But what happens to their patients in Canada, right? Without anyone.
There is the old joke, where's the best place to find a good physician, a good Canadian physician in December? And the answer is in Florida.
That's right.
Because they've run out of money. If you'd like to talk to Twila Brase with the Citizens Council for Healthcare Freedom, the number is 1-800-351-1212, 1-800-351-1212. If you have concerns about Medicare for All, about electronic medical records and what's happening there, or just a basic question about the healthcare system, 1-800-351-1212. So, Twila, they're pushing Medicare for All. One of the things that has struck me as interesting, since you are a nurse, there are nurses' organizations that seem to be all for this. They seem to be 100% behind it. Why? There are nurses' organizations that are just plain leftist. Why is that?
Well, I have somewhat wondered the same myself. It may come from this, desire to not have to deal with patients who can't pay and choose not to come in, and they don't want to have charity, right? And so this idea that if we're all just covered, it just, deals with all of these situations of patients who have lower incomes or less access, or, it's like compassionate, right? But it's not compassionate. And I don't know if they don't know. They haven't looked at what has happened in other socialized medicine systems. If it just sounds good, I'm uncertain. But it is always difficult, like with Hillary Clinton's plan, right? They really like that plan. Yeah, that was a complete takeover.
One of the freedoms that we're likely to lose for health care providers is that in the legislation, and I did not realize this until I saw Chris Jacobs with the Texas Public Policy Foundation writing in the Federalist, had an article on this, and his article is available on pointofview.net on the website there on today's program. But he sort of takes away there's any conscious objections to providers who don't want to take care of, say, an abortion. They don't want to provide an abortion, don't want to take care of a transgender patient, or various issues that sometimes arise there, whereas some states are trying to ensure that there's that health care freedom. The single-payer legislation that's coming out seems to take that away. Is that a concern of yours? Yes,
because, of course, the doctors then become government employees. That's what happens in a single-payer system. They become government employees, and then the government will tell them who they have to take care of and what kind of procedures they can do and what kind of procedures that they can't and what procedures they must do. And so I just, for your, what you said about the transgender, I think that every doctor and every nurse wants to take care of a transgender patient. But yes, I don't think that all of them are willing to help mutilate the body or change the hormonal structure of a patient who wants to be a different gender, because that gets into something different. I think every nurse and every doctor would want to do everything possible to care for a transgender patient for whatever is happening, but they don't want to do the surgery or be forced to give the pills. And now, of course, there are places who want to tell parents that, young children, really young children, age 5, age 7, right, should be given meds to deal with the fact that, the little boy thinks he wants to be a girl, right? And there are doctors who absolutely, this is like completely against their medical ethics. It's completely against biology. And so they don't want to be forced to do that.
It's an interesting change that has developed here, because typically in years past, the patient went to the doctor if the doctor was willing to take the patient, and doctors would step in. If you had a medical emergency, doctors would step in, but a doctor didn't necessarily have to take a patient, and the patient didn't have to go to a doctor. But that's sort of changing here. If we've seen the gay community say, let's target certain bakers and go in and try to force that baker, who may be a Christian, to come and serve our wedding or whatever and develop a cake for our wedding. So we're going to target that person to create a case. I assume you could see something like that happening in the medical community, where activists say we're going to go target a medical provider and make them provide this, and if not, we'll sue them and take it to the Supreme Court.
That's right. And that's what will happen, because that's how the push goes. There's already, was it yesterday or the day before, that New York filed a lawsuit against the Trump administration's conscientious freedom of conscience rule. So there's no doubt that it'll happen by litigation, or it'll happen by legislation, and whoever is in power will do this. But the interesting thing about the Constitution, and that's where it's got to get to, what does the Constitution say? The Constitution says that minorities and minority beliefs are protected under the Constitution. So no matter how many people vote in Congress or at a state legislature that we're going to force you to do this, you can't be forced to do that which violates your constitutional rights. And so that's where we'll get down to. That's where it's getting down to with the bakers. That's what is going to happen at the medical level. Just imagine being a doctor who's forced to give someone a medication that you believe will harm them, who's forced to change body parts that's permanent.
Yes.
You can't take it back. And there's so many people now who are transgender, who had the surgery, who are speaking out and wishing that they'd never done it, right? But you can't undo most of that. You can't undo it.
You had raised an interesting point a minute ago, because you mentioned doctors are going to be getting their money from the government, and therefore they're working for the government. I've heard Bernie Sanders say, well, what he's proposing isn't really a government-run health care system, because the taxes go to the government pays the bills, but the doctors, the hospitals are not owned by the federal government as they are with the VA. The doctors are not employees of the federal government, because the money is going to the doctors, and so that's the way it's set up in Canada, whereas in England, You actually work for the government if you're a doctor there. The hospitals are owned by the government there. But Bernie says this isn't a single-payer system. But to your point, if the government's paying if all your money is coming from the federal government, the government essentially decides what you can and can't do. We've got about 40 seconds left before the next break.
So Medicare, just look at Medicare. Just look at all the controls that the federal government is imposing on Medicare. Look at their national coverage decisions. Look at what they decide that money is available for. Look at the fact that in fee-for-service medicine, they've taken 11 million seniors and put them into a managed care system secretly, where those doctors and hospitals have a limited pot of money to care for their entire population. That's what happened.
And we'll be back with Twila Brase in our closing segment here in just a minute, so stay with us.
Now, back to Point of View, your listener-supported source for truth.
And Merrill Matthews, we're back sitting in for Kirby Anderson, and we're in our last segment with Twila Brase, president and co-founder of Citizens Council for Healthcare Freedom. That's a patient-centered national organization based in St. Paul. And in addition, she has published a book, Big Brother in the Exam Room, looking at the issues behind electronic health records. Twila, we're not going to be there for a while, I don't think. But what if we were to start from scratch? If we were to have a do-over on healthcare, what should we be doing?
Oh, well, well, we have got to go back to access to indemnity policies, real health insurance. It's there for the catastrophes. It's there for major medical. We really shouldn't have the health plans with their limited network. Health plans are prepaid coverage. They're not true insurance. Patients should be paid by the insurer and then pay the doctor and the hospital themselves. That would take out all the third-party payer costs. That would take out all the third-party payer controls. We should have access to insurance for a lifetime. And I really support the idea of what we call pre-birth coverage, the idea that parents could buy indemnity policies for their children before the child's born, hand it off to them when they reach the age of maturity, and then the child is never trapped by employer-sponsored coverage or by family coverage where they get a catastrophic condition during that time and they feel like they can't leave their job. Or, of course, once they reach age 26, they age out of their family policy, and then there they are with a so-called pre-existing condition. We should get rid of the pre-existing condition problem by people owning their own policies and getting their full pay at work, their entire compensation, not in these policies that are just, limited to their employment. Those are a few things.
It's an important point because I think people sometimes push back. We've had employer-based health insurance, Medicare and Medicaid for so long that people just don't sort of think, how could insurance work like that? But virtually every other kind of insurance, auto insurance, you buy your own auto insurance policy, you buy your own homeowner's policy. If you have hail damage, last time I had hail damage on my roof, I do live in Texas, the insurer came out and they wrote us a check. If you have an auto accident, the insurer comes out, does that, they adjust it, write you a check, and the check is there in your pocket, and you can go to wherever you want to have your car fixed, or in some cases you may decide not to get the car fixed. So what you're saying is health insurance ought to work a little bit more like every other type of insurance. Is that right?
That's right. It should be real insurance because, see, today it really isn't. It's just this prepaid coverage where you pay all this money in advance, and then the health plan, by law, can say that no. We say no to the care that you need or that you want, and we're in the middle, and so we can decide whether to pay your doctors or your hospitals, and that limits your access to care. So for a healthcare story, like you were talking about, hail, I had a guy who was probably 80 years old tell me that in the early 1970s, he had to have heart surgery. So his indemnity insurance policy sent him a check for $68,000, which he used to pay his hospital and his doctor. He had to have heart surgery again the very next year, so they sent him a check for $72,000, which he used to pay his hospital and his doctor. And he said to me, it was so simple. And it was, right? And nobody was interfering. He could go to any doctor, anywhere, any hospital, anywhere. There wouldn't be all of this interference and all of this money stripped away from people by these third parties having their fingers in there. So, yes, absolutely, it should be that way. And the other thing that there should be is charity. So the thing about the medical system is it was built on and has a foundation of charity. But charity is being driven out of the medical system. And I like to say that we're losing the mission of medicine and it's being subverted to the business of healthcare. And one is warm and one is cold. And the fact of the matter is that doctors and hospitals can give patients care charitably, cheaper than if they have to go through the entire process of Medicare and Medicaid. Mm-hmm. All the billing that's required, all the going back and forth and verifying that this is true or you missed a code and so we're not giving you the money and so you got to send it all back, right? They can give it better charitably. Plus, it builds gratitude in the patients as opposed to entitlement. So if we had to do it all again, that's what I would do. And not only that, but I would move back there. Move back there.
The president is trying to move us towards having more disclosure on healthcare pricing. I'm sympathetic to the notion that patients have access to healthcare prices. The problem, it seems, in the system we're talking about, where I go to the doctor, my employer's insurance or Medicare or something pays for that. As a patient, I don't have a lot of incentive to ask for prices because somebody else is paying the bill, and I'm sort of removed from that, and that has helped drive up healthcare spending. Do you think?
I agree with that, although I will say under the Affordable Care Act, it has really driven up the deductibles. So now more people are indeed going shopping. And a lot of people have switched to healthcare sharing organizations instead of insurance, or instead of these health plans, right? And so that's all cash-based, and so they are negotiating with doctors. They are asking for prices. And so in my opinion, that's the only good thing about the Affordable Care Act, is that people started thinking about prices again and started with believing that they could go shopping. And like 90% of medical expenses are not emergency. So you should be shopping for all of this. Go to metabid.com, right? Use health sharing, which is so much cheaper than insurance. And by the way, we have for those who are listening and haven't even heard about this, in 2010 I did a report, and it's on our website at cchfreedom.org, cchfreedom.org. Just put in healthcare sharing, and it'll all pop up.
The rising deductibles was a surprise to Democrats. They thought it was the deductibles were going to go down, and they sort of claimed that healthcare spending was not growing as fast as it was. And I would argue that one of the reasons why it did not grow faster was the fact that the deductibles went up so high, $7,000 per person, $14,000 for a family. It's outrageous, and yet Democrats still claim that's good insurance.
Well, and I would say it's outrageous for what they claim that you have, right? If you had a true indemnity catastrophic policy, you could be paying $100 a month for that thing. And you'd have that kind of deductible, but you'd be paying $100 a month, and you'd be preparing for that deductible. But now you've got these huge deductibles, and you've got these outrageous premiums. And, of course, you're seeing nothing back from the health plan, because they're just keeping it all, and they are just growing by leaps and bounds and lots of money because of this situation, while patients are suffering because they're having to pay the entire price themselves, the premiums and the cost of care. And it's only if you get, in a car crash or you end up with cancer, do you actually tap into this coverage, and then they can tell you no, right? Because that's what health plans can do. They can tell you no. Indemnity insurance can't tell you no.
We've got some real challenges facing us on health care, and they're liable to get worse. Twila Brase is president and co-founder of Citizens Council for Health Freedom. She is the author of a new book, Big Brother in the Exam Room, The Dangerous Truth About Electronic Health Records. If you want to know more about Twila, you can go to pointofview.net. We've got her picture and a bio up there. We also have a link to her book so that you can find out more information about that. I believe it has the chapters and so forth outlined, so you can see all the information about that and learn more about her and check out other things that they're doing at the Citizens Council. So, Twila, thank you so much for joining us. Very interesting, and we wish you well on those efforts. Thank you. We're going to continue talking healthcare when we come back with Mark Litow, who's been involved in health policy for many, many years, and we'll begin to look at some of the Medicare for All specifics. So stay with us, and we'll be back.
It wasn't long ago it seemed every official decision brought religious liberty and our ability to live as faithful Christians into question. Some of us wondered how long it would be before we were literally forced to choose between obeying God or men. That pressure seems to have subsided just a bit, and now is the time not to take a breath, but to work as hard as we can for the future of our nation. Thanks to you, Point of View is doing just that. And our special thanks to those who have become members of Truth Team 360. In football, 22 guys battle it out on the field while 40 or 60,000 watch in the stands, and perhaps hundreds of thousands more watch on television. We need a special few to get out of the seats and into the game. Join today by calling 1-800-347-5151 and ask to join the Truth Team, or visit us online at pointofview.net/team. We really do need you. The nation needs you. 800-347-5151 and pointofview.net/team. Point of View will continue after this.
just want to thank you so much for all the wonderful programming you have. You're just absolutely fantastic.
I recently started listening to Point of View, and I really found it interesting because of the different subjects you cover. Thank you for that.
I really appreciate everything that you do in keeping us informed.
Thank you, Kirby, for everything that you have been doing. I appreciate all the work that you're doing, advocating for the Word of God. Thank you so much.
Point of View, I think, is absolutely necessary because it's a Christian perspective, a biblical worldview perspective, and receive very current, up-to-date information about what is really going on, week to week in our culture, which is changing so rapidly, and yet it's morally sliding backwards.
Yeah, first of all, I think y'all's program is wonderful, and enjoy it every day. I learn so much every time I listen to it.
Point of View Radio Talk Show.
Hi, this is Kirby Anderson. You know, each day we take on the tough issues and provide a biblical perspective to them. The topics we cover are wide-ranging. Apologetics, theology, prophecy, creation and evolution, intelligent design, marriage, family, child-rearing, the millennial generation, trends in society, politics, economics, business, religious liberty, the Constitution, public policy, foreign policy, military policy, tensions in the Middle East, abortion, homosexuality, pornography, sexual ethics, media, technology, history, and America's godly heritage. We talk about anything that affects your faith, your family, or your freedom. So don't go anywhere, because Point of View starts right now.
Across America, live. This is Point of View. And now, your guest host for Point of View.
And welcome to Point of View. Merrill Matthews with the Institute for Policy Innovation, sitting in for Kirby Anderson today, and we're talking about health care, especially Medicare for all. So we've got we're talking on one of the topics that is affecting everyone. With me this hour is Mark Litow. He is an actuary retired from Milliman Inc., an actuarial firm. That's a worldwide consulting firm. Mark retired in 2011. Milliman has over 2,500 employees, and they do worldwide consulting. Mark was also a principal with Milliman for a number of years, based in Wisconsin. He was also on the board of governors of the Society of Actuaries, and for 4 years he was the director of Milliman's international health issues. And looked at healthcare systems in other countries. And Mark and I have co-authored a book, On the Edge, America Faces the Entitlements Cliff, which is available for download at IPI.org. Mark, thank you for joining me.
Thank you for having me.
Mark and I go a long ways back. We've known each other for a number of years, and in my think tank role, I've sometimes we contracted with Milliman and Mark specifically to look at a number of different healthcare issues. So we've been looking at these things for a long time. Let's start out, Mark. But you're an actuary. Tell people what an actuary does.
Well, we tend to assess risk situations. It can be for government programs. It can be for insurance companies, for hospitals, in healthcare, drug companies. So we tend to work for all kinds of organizations.
And the as a firm, Milliman covers. You have bases in a number of countries around the world, don't you?
Right. I worked in about 12 countries. I helped manage a practice in Hong Kong and also in South Africa for a number of years. So had experience with a number of single-payer systems as well as other systems.
Well, let's jump into that issue, because Bernie Sanders and a number of people tell us if we would only adopt some of the healthcare systems similar to what they have in England, what they have in Canada, what they have in so many of the other countries that have a government-run healthcare system. Some of them, they vary a little bit in how that works. But Bernie says if we just would adopt something like that, we would get much better health care at much lower prices. What's your experience on the international level?
Well, all the countries that have single-payer systems over time develop lots of issues, primarily with access to treatment. And typically they'll become almost more two-tier than anything you would see here. People think there's access problems, but because all the governments use price controls in one form or another, and that tends to, they'll start to limit, some people call it ration, but however they do it, they'll limit it to control the cost. So usually single-payer systems, will end up in the developed countries outside the United States. Typically you'll see 10 to 12% of GDP. Here we're at about 18%. So we give a lot more latitude to our people, a lot more choices. We have a lot of problems because a lot of the rules don't create a lot of efficiency in a single-payer system, they will limit costs, sometimes reasonably and sometimes unreasonably so, but they will get a lower cost. In theory, they have all people covered, but really getting access to treatment when you need it can be a serious problem.
Now, you mentioned that many of those countries spend, say, 10 or 11% of their gross domestic product, GDP, on healthcare. We spend more around 18%. And so what Bernie will say is, see how much less they're spending and they have better access. He implies that they are spending less because they're better and they're more efficient and they're not wasting money. But in fact, what happens in most of these countries is that the government just says we're going to spend X number of dollars on health care. That's how much is available to you as who are healthcare providers. We've got this much, and that's how they limit it. It's not because they're necessarily more efficient. Is that correct?
Well, yes. So in England, for example, they have 153 regions. They give so much money to specific hospitals, specific clinics, and so forth. And if they run out of money, you need a surgical procedure, and they don't have any more money left, you'll wait. Canada does a little differently, but it's the same type of an effect. So in certain times, you may be up near the front of the queue, and sometimes you may wait a long, long time. At least in those countries, the more well-to-do people, if they're in a lot of pain or their life is threatened, they'll come here or they'll go elsewhere. But if you have that kind of system, then ultimately you will tend to face those kinds of problems.
There was I think it was a Facebook story a lady put up. She was in Canada. I think she was in New Brunswick. And I wrote about this here a few weeks ago. But she was a younger lady, I think about 33. She needed to see her doctor about some lesion. She was concerned that she might have, I think it was ovarian cancer. It was ovarian cancer. She was concerned, but because in Canada, you have to go through the primary care doctor in order to be able to access a specialist, she couldn't get an appointment with her primary care doctor. And what happens in Canada is that occasionally the primary care doctors retire, they move. If you lose your primary care doctor, then you have to try to get in line for another one because most of the primary care doctors have already got full schedules, a full list of patients. They can't get to you. So she went for 2 years before she could get to see a primary care doctor who could then refer her to a specialist, and by that time the cancer had so metastasized. I think she's in stage 3 now. She says she's getting the treatment, but she says I'll never be able to have children again because I'm having to get such severe treatment now. If I had been able to see a doctor in the early days when I first had these concerns, I would have been able to be treated and I'd be back in force. But she's got major medical issues now because of the waiting, and she was telling her the premier of her province, I want you to look me in the face and tell me our healthcare system is fine because I've had to suffer through it for 2 years. But that's not unusual in those systems. Is that correct?
No, well, not at all. And that's how sad is that. But the issue is in almost all these countries, what happens is you have many fewer doctors per 1,000 population. So Canada has many fewer doctors than the United States. And, as we've put more and more people in our government programs here, whether Medicare, Medicaid, veterans, Indians, and so forth, we're seeing greater and greater shortages in certain areas. Waiting lists can get longer. And it really varies by area. Some areas there aren't a lot of problems, and in some there's a lot. It may be cardiologists in some places have become very difficult to access. Primary care docs are tough, and of course for certain populations like Medicaid.
Mark, hold that thought.
Really
We're going to come back. We're going to come back and talk more about the problems in other countries, and especially the problems we are facing as we move to Medicare for all. We'll be back in just a minute.
This is Viewpoints with Kirby Anderson.
Sometime in the near future, America will go over the entitlement cliff. That is the argument of Dr. Merrill Matthews, co-author of the book On the Edge, America Faces the Entitlement Cliff. He was on the Point of View radio talk show recently to discuss the problem and possible solutions. The first part of his book explains why entitlement programs fail. To put it simply, they are not actuarially sound. But the problem is even greater than that. He also shows how the cost of entitlement programs always exceeds projections. He details the expansion of Social Security, Medicare, and Medicaid. The second section projects how America will fall off the entitlement cliff. Not only does he provide projections for Social Security, but also for the impending pension crisis, the welfare debacle, and the health care debacle. This is true of both private sector pensions as well as for public sector pensions. He also includes sections on stepping back from the cliff. He deals, for example, with the fact that we have different types of safety nets in society that result in different outcomes. We do have examples in other countries of how to construct a sustainable safety net, and I wish some members of Congress would read the sections on principles of a sustainable safety net and embracing actuarial principles. There are solutions to the financial challenges we face with entitlements, but we also need to elect a Congress, politicians who actually want to solve some of the problems created decades ago with these government programs. So far, most members of Congress, unfortunately, want to ignore the fact that sometime in the future we may go over the entitlement cliff. I'm Kirby Anderson, and that's my point of view.
For a free copy of Kirby's booklet, A Biblical View on Anti-Semitism, go to viewpoints.info/antisemitism. Viewpoints.info/antisemitism.
You're listening to Point of View, your listener-supported source for truth.
Merrill Matthews, welcome back. I'm sitting in for Kirby Anderson today, and with me is Mark Litow, a retired actuary and principal from Milliman Inc., the actuarial and consulting firm, and Mark specialized in health policy. So, Mark, we've got Bernie Sanders saying these other countries that have single-payer healthcare systems do so well, but he doesn't think we do. We have an employer-based healthcare system where roughly half of the country gets health insurance through an employer. How did we end up? Give me the short history of how we got an employer-based health insurance system.
Well, it came out of World War II. There was, it actually passed in 1954, but it started before then. There was a lot of pressure. People couldn't really take wage increases, so they wanted to, get people increases in at least in so-called income, and they did it by providing much richer health benefits, and then they declared that was called a premium tax exclusion, which gave basically you could deduct all those things. So that quickly changed the system from one where people were paying to where third parties were paying. Insurance grew dramatically.
And then in 1965, we passed Medicare and Medicaid, Medicare for seniors, Medicaid for the poor. But when they did that, the idea was that we need to have a government program to help them. The Medicare, as soon as that started going, healthcare spending just exploded then, didn't it?
Oh, yeah. And interestingly enough, the reason, if you go back and you read some of the testimony before Congress, people were complaining that the greedy insurance companies were charging them a lot of money when they hit 65, because they their employer was paying the vast majority of the cost, and suddenly they were expected to pay it because now they're retired. And so people complained, and really that's why we got Medicare. They thought the insurance companies were gouging them, and it was simply because there was no employer there to pay the cost anymore. And then they passed Medicaid. Well, if we do it for the seniors, we got to do it for the poor. So that's really how the premium tax exclusion led into all that.
And what we did was we essentially insulated employees from the cost of their health insurance. We insulated seniors and the poor from the cost of health care. And as a result, because people weren't out there shopping for those things because somebody else was paying for it, we saw prices just start exploding in the healthcare system, which ended up bringing in managed care. How did that come about?
Well, the system had a couple of really huge shocks in the 70s already. As you mentioned, healthcare was exploding. Prior, back in World War II and before, healthcare had never been more than 2% of GDP. It was quite a bit less. And by this time already, it's getting up there. And then you remember the late 70s with the high inflation. And interest rates, I think, were around 18%. I remember our first mortgage, pretty shocking compared to what it is today. And healthcare costs at that time were going up like 30% a year. So in the late 70s, and we had the threat of, under Jimmy Carter, of national health care. And then it went into the 80s, and the costs, a lot of costs came down some. They were always going up much faster than regular inflation. The affordability just kept getting worse. So Medicare put in some rules called diagnosis-related groups in '83, which worked for a couple of years, and then healthcare costs in the late '80s again exploded. And in this period of time, to try to deal with this explosion of costs, both in the late 70s, managed care started to come into being as a way to try to control costs. And then, of course, you got the problems in the late 80s, and then it really took off. But ultimately, there was quite a backlash because people were saying, well, you're controlling costs by trying to limit our access to treatment. Mm-hmm. So we're right back to the same access issue. But that's really what led to the managed care and has led to a lot of other changes over time because we just haven't, the costs just keep going up and up. And the more rules we've put in that we're supposed to control costs, but they haven't.
1-800-351-1212 if you want to talk to Mark Litow about the healthcare system and health insurance. And then, Mark, come the early 90s, Bill Clinton becomes elected president. He campaigned on healthcare reform. They tried to create the Clinton healthcare plan. Took us a couple of years, but eventually Congress sort of voted that down. But from that point on, it seemed like Democrats were intent on trying to get some kind of national health care program passed, finally succeeded with the Affordable Care Act in 2010, and that went into effect in 2014. How's that working out for us?
Well, it hasn't worked very well. The promises that were made, it was supposed to be more affordable. If I recall, they were saying it was going to drop rates 25%. And in fact, rates have gone up pretty considerably. For individuals, they've really gone out of control. And of course, the only thing that helps individuals are the subsidies under the exchanges. But for people not eligible for that, that has been a real problem. The small group market, which actually deteriorated from the time HIPAA was passed. Most people don't realize when HIPAA was passed in 1997, they put in certain rules for small businesses of generally 2 to 50 employees, mm-hmm. and that caused the rates to skyrocket in that market under what's called guarantee issue and community rating provisions, which vary some by state. But you remember Obama said that the rates in the small group market were 20% higher than large group, which was an accurate statement, roughly. And that's really due to that provision in the 1997 law. So it's been a series of things. It's not just ACA, but ACA has clearly exacerbated the problems. in the system.
And I will point out that you and I had a piece in the Wall Street Journal in January 2013. That was a year before the legislation actually went into effect. It passed in 2010, went into effect in 2014 on the health insurance provision. And you and I sort of highlighted what was going to happen with this. We made some predictions about how what was going to happen under Obamacare. And not only did we turn out to be right, I would argue we might have been a little bit on the low side. But we explained
it's not one of those things you want to be right about.
We wish we were wrong, but we turned out to be right. And Kathleen Sebelius, the Secretary of Health and Human Services, came out, I think, the next month after we did that and said, no, none of those things are going to happen. This is going to be great. We're going to see health insurance premiums go down, access and choice go up. And she, of course, was wrong, and she ended up having to leave shortly after the later that year after the Obamacare rollout of the internet, their website rolled out, and it was just such a disaster. But we've had those problems. Now, because Obamacare has turned out to be such a failure, Democrats are stepping up and saying, well, look, health insurance premiums are high. People have access problems. Excuse me. That's because of the legislation that you passed. So now we need a single-payer health care system. And there's several out there. Mark, what's your general sense of how these things would work? We've got about 2 minutes left in this segment.
Well, they seem to be, for the most part, patterned after expanding Medicare to all people. So Medicare has a whole series of different provisions which are effectively price controls. They have something for hospitals, which is called diagnosis-relating groups. They have something for physician or professional, which is called RBRVS, or Resource-Based Relative Value Schedule. They just got a new thing that they have Part D for drugs, and they're doing things. They've got a 340B provision. There's just a lot of details, but the bottom line on all these things is they keep lowering the prices that they pay for providers. Then they keep changing rules, and as they lower the prices, the list prices, it's almost like a department store sale, keep going up. There's more gimmicks to try to deal with it. Then they have to create more rules to try to control all the behaviors by the various parties, whether they're the providers, the insurers, the consumers. And it ends up, as price controls always do, an incredibly distorted mess. And if you want to see what happens, you can look with price controls. You can look around the world at things where you try to put price on oils and other things, like in Venezuela. What happens? And you get big problems with supply demand.
1-800-351-1212, 1-800-351-1212, if you'd like to talk to Mark Litow about the healthcare system and your concerns about some of the things that are happening in Washington as they look at expanding to a Medicare for all, a government-run health insurance system. So we'll be back with Mark in just a minute, 1-800-351-1212, if you'd like to talk to Mark Litow. We'll be back.
Why should you become a partner with Point of View Radio? Because for decades, this team has made a significant difference in lives and communities across the nation. Because America is dying for lack of biblical wisdom about life and culture. You should give because your gift will make possible cutting-edge information on issues that matter, information you won't hear anywhere else. Why? Because your gift will change lives, because you'll influence our culture with biblical truth, and because you can make a difference for the future. Our nation needs a truth team very badly. Support Point of View Radio today at pointofview.net. Click on Join the Truth Team and choose your level of support. Pointofview.net, or call 800-347-5151. 800-347-5151, or mail that first donation to Point of View, Box 30, Dallas, Texas 75221. Box 30, Dallas 75221. Point of View will continue after this.
You are listening to Point of View. The opinions expressed on Point of View do not necessarily reflect the views of the management or staff of this station. And now, here again, your guest host for Point of View.
Welcome back. This is Merrill Matthews sitting in for Kirby Anderson, and with me now is Mark Litow, a retired actuary and principal from Milliman Inc., an actuarial firm. And Mark especially has been in health policy for all these many years. So, Mark, let's take a couple of issues that we hear from them. Number one, they talk about costs. They say it's going to save money, and yet there are estimates out there that we're looking at, and this is available on pointofview.net. If you click on today's program, we have some links to this. One of them is on the cost of Medicare. The Committee for a Responsible Federal Budget has posted several of the predictions of how much it would cost. Most of them run in the sort of $30 trillion range. Chuck Blahhouse has put it around $32 trillion. The Urban Institute, which is a liberal group, puts it around $32 trillion. So there's several that are in that sort of $30 trillion range. Mark, that's a lot of money.
It sure is. Our deficit now is about $21 trillion, and that, of course, doesn't include present value of any future liabilities, just currently what we owe. But the reason is when you put in programs that other people pay for, your utilization goes up a lot. And so Medicare, for years, has much higher utilization than you would see in an under 65. Once you adjust for age, you adjust for health status differences. It's just that when you have those kinds of open-ended allowances for things, you're spending somebody else's money, people will use a lot of it. And then the government, as we talked about, comes in and puts in some form of price controls, so they pay the providers much less than the private market does, and then those types of provisions create all kinds of other problems. Now, this has been going on, as I mentioned, for years, and despite that, Medicare, Medicaid, the costs are just running out of control, and they have been for a long time. And the more they go out of control, the more they're going to put in these price controls. And ultimately, that can result in shortages of medical personnel and infrastructure.
1-800-351-1212 to talk to Mark Litow. We've got Brian on the line. Brian, I'm going to come to you in just a second. Let me address one more thing with Mark. Mark, back about the mid-2000s, I sponsored through Milliman, a study on Medicare administrative cost, because we heard then, and we're hearing again, that Medicare is so efficient financially that it only takes about 2% in administrative cost, and the private sector is much more expensive. But when you did that, you pointed out that, in fact, Medicare isn't nearly as inexpensive as people want to claim, and that the private sector, some areas are expensive administrative costs, but especially if you get to a large employer that has large economies of scale, it's not as expensive as one might think.
Well, right. In fact, Merrill, that study is now well over 10 years old, and if we were to update it, it would show that Medicare is actually quite a bit more expensive now than the private market. And the reason is pretty simple. The government does not do what we call functional cost analysis for accounting purposes. So when a company, whether it's a health insurance company or any company, does business, they have to account for all the investments, if they loan money, all the functions, whether it's underwriting, paying claims, collected premium, managing. They don't do that in government. So when Congress spends time, or the president spends time, or whoever, they don't allocate it. That's just put in the executive branch or the legislative branch, whatever it is. And the interest on the deficit, which is probably around $300 billion a year, it's just a number. It doesn't get allocated to anything. So what we did in that study back in 2006, and we did an earlier version in, I believe, in the mid-1990s, which I think you can actually access online, they show how the costs over time were increasing, and that they, at that point in time, they had already reached pretty much a similar level to the private market, and by now they would have definitely, and it's just because we have all these other costs that aren't accounted for. So the more these programs go into deficit, the more you're going to see that the costs of these programs actually are greater. And of course, if these programs cost $30 trillion, the deficits will grow dramatically. So the cost of these programs will far exceed to administrate what the private markets are.
And just to sort of sum it up, with Medicare, when they talk about the 2%, that's what it costs to write the checks for seniors who are using healthcare system. If in the private sector, that's just paying the claims. In the private sector, you've got to account for employees, rent on the building, health insurance for the employees, all these other things that are covered, that are paid for by taxpayers. It's just not in that 2% figure. All right, let's go to Brian and in South Carolina. Brian, you've got a question.
Thank you for taking my call.
Sure.
I have no animosity against lawyers, but legal liability is the largest part of healthcare expenditures that can be readily reduced. The key to cutting the costs of medical malpractice, surgical errors, negligence is to require the patient to assign his own liability limit at the time of entry into the healthcare system. This allows the provider to lower his own charges based on that patient-assigned liability, rather than charging every patient for an open-ended liability tending to infinity.
Mark, you have an answer?
Well, yeah, the litigation is a problem, but the problem is most things in healthcare, the system's very interactive. So what happens with litigation relative to the Medicaid population was poor, and Medicaid, by the way, is just exploded under ACA, and almost 1/4 of the entire population. If you go on the debt clock, you'll see over 76 million people on that program. And unfortunately, the way it works is many physicians do not participate in Medicaid, and so a lot of the people end up going to the emergency room. When they go to the emergency room, they see someone who's never seen them before, and unless they can figure out what's wrong with them quickly, they put them in the hospital to try to, as the defensive measure, to avoid the lawsuit. So now you have the cost of the lawsuit and all the things that entails going through the system. Plus, you end up with much more expensive care, and probably, based on the doctors I talk to, generally probably 80 to 90% of these people don't need to go in the hospital. So now you got the cost of the emergency room, you got the cost of the hospitalization, and all that entails, and the taxpayers, of course, are paying for all that. So the effects of litigation on the system are many, and it's a real problem.
And it affects certain things. I mean, there was a time, and I haven't seen these numbers for a while, but there was a time in some states on OBGYNs that the cost of their liability, their malpractice insurance was so high that I believe they were either limiting people or they weren't going to the emergency room to see people. The OBGYNs just could not afford to cover all the malpractice insurance they were facing.
Sure, and of course there's probably been a number that have given up their practices as a result, so then that creates access problems. That's why I say there's just so many interactions, and many of them, when you get into these situations, are very negative. So
1-800-351-1212, 1-800-351-1212, and let's go to Barbara in California. Barbara.
Hi, thanks for taking my call. I'm 73 years old and on Social Security, and I'm paying for my Medicare. I thought everybody was.
Well, no, most people are, but if you're poor, if you meet a threshold below the federal poverty level, then Medicaid will actually pay for your Medicare sub-premiums. But you have to meet those thresholds as you do on any. There's income and asset tests for all of Medicaid.
But
you're right. Most people are paying get their Social Security and they take the money for Medicare right out of there.
Right. They're paying premiums. You're paying premiums for Part B if you take that, and Part D if you take that. But, Barbara, those premiums only cover about 25% of the cost of Part B and Part D, the prescription drug benefits, and then Part B is the physicians. So taxpayers are covering the other 75% of that. And, of course, those of us who spent years working, you were paying the Medicare FICA tax, the Medicare payroll tax. So that's certainly part of something that we pay for. But taxpayers are funding an awful lot of Medicare right now. So, Mark, we're going to take a break here in just a second, but 1-800-351-1212, 1-800-351-1212 if you'd like to talk to Mark in our closing segments about the health care system. But we've got some real challenges facing us now, and as the system's become such a mess, it's going to be hard to reform. So if you want to talk to Mark, give us a call. We'll be back in just a minute.
Now, back to Point of View, your listener-supported source for truth.
Merrill Matthews sitting in today for Kirby Anderson, and with me is Mark Litow, healthcare actuary, retired now, and we're talking about a number of things on healthcare. And Mark, we just should take a minute to mention that we have that book, On the Edge, America Faces the Entitlements Cliff, where we look at healthcare, welfare, Social Security, all these entitlement programs, and it's available If you want to, if you go to pointofview.net, click on the show today. We have a link up there with a PDF that you can download it, or you can order it from IPI.org, so you can take a look at that. Mark, this whole healthcare issue is going to create huge new financial problems for us. Do you see any hope for us? I mean, do you think we're going to end up going towards Medicare for all? Are people just so frustrated with all the problems that we have right now, many of them made by Obamacare, that they're just going to say, let the government take care of it. I'm tired of messing with it.
Well, certainly that's a risk. I mean, I think you have to have hope. We've both been looking at this for a long time, but I think it really comes back to we have to look at what the fundamental principles are: actuarial, economic, medical, and accounting. And we've violated just so many of those over this long period of time. So, yeah, ACA has been a problem, but as I mentioned, this goes back to World War II, and we've made a mess of this over 70 some years. So it's going to take a lot of effort, but we have to get together and look at those fundamentals and the standards of practice and put in efficiency. And I really, think, Merrill, that it starts probably in an area they really haven't looked at, the tax code, and it's linked to all the safety nets. The countries around the world generally have not figured out how to do safety nets where you give subsidies to people. And you need these safety nets. It's not like you don't need a Social Security and a Medicare. You do, but you have to learn about these principles, how to manage it over time. And then we obviously have to transition because we've created some real problems, and you're not going to get out of them overnight. But if you start going the right direction, ultimately we can do that. And if we don't, the risk is it's linked inextricably to the economy.
Yeah.
And if the healthcare system goes down to a point where people are not getting sufficient healthcare services to meet needs, think of what that does to the population health status. People are sicker, they're less productive, and so it'll have serious economic ramifications. And of course, we get more people on entitlement programs that pushes up our benefits we're paying out. As we talk about, it pushes down economic participation and productivity, and so we got benefits going up, costs going, revenues going down. So the government has less money, and that's already happening all over the country. It's affecting rural areas severely.
Yes.
It's affecting how much money is spent on education. So and a lot of other areas, our infrastructure. Healthcare is taking money from a lot of other needs. So
let's go to Shelby in Georgia. She has a question for us. Shelby, you're on the air.
Well, the question is how I'm blind. I'm disabled, blind, and I've been trying to get doctors to do a full eye examination. And I'm being told it doesn't matter because of the condition of my eye. How do I hold these doctors accountable?
Do you have a suggestion for him, Mark?
Well, I'm trying to understand. You're having trouble getting in to see the doctors, or they're not giving you the care you need, or what is the issue?
They're denying me a full comprehensive eye examination.
How are you covered? Do you have insurance protection either through private or the government, or what is your situation?
Well, the situation is I'm going through a third party to get the proper information, so they have the information in there so they can help me advocate for me.
So you're in a private carrier where there's a pre-authorization of this, and that's holding it up. Is that the problem?
No, it's called Voc Rehab. I'm supposed to get rehabilitated through Voc Rehab, and I'm trying to make sure they have the right complete information in my caseload so they know what's going on with my eyes, so they can advocate for me.
You know, Shelby, it sounds like you have a complication. I'm not sure we're going to be able to help you, but I sure hope you're able to find somebody who does. I'm just not sure Mark, given where he is going to be able to help. So let's go to our next caller. Carolyn, you're on the air. You've got a question about Medicare for All?
Yes. Well, it will not work. I am 75 years old,
Mm-hmm.
and I worked in the healthcare field as an operating room for 43 years. So I'm well acquainted of the costs of care. And when I go to the doctor, I get the medic. You know, you can't pay, which is a silly act, right? And, you know, why shouldn't we, if we can, pay? But anyway, I get my statement then and see how much the doctor is paid. And it is just disgusting. Like, my husband just went to a doctor for a physical, and the charge was $265.
Mm-hmm.
Medicare approved amount was $142. And
Yes.
then it says amount Medicare paid, nothing. And we don't get the bill for that.
Well, we've only got a few minutes. Hold on just a second. We've only got a few minutes left, but let's get a quick answer on that, because what the hospitals or doctors bill and what are actually paid are oftentimes two different things, Mark.
Oh.
Yeah, in fact, on the models that we're working on, it shows Medicare probably pays closer to 30% of the actual bill. Now, that varies, you know, all over the place by type of service. Medicaid pays even less than that on average, and that's off of undiscounts. So the private market has huge discounts too. So, but this is, you know, I talked earlier. This is what happens when you have price controls, because they'll say the government negotiates, but the government doesn't negotiate. The government basically sets the prices or the types of services they'll render. And this has caused, you know, if you're talking about your bills, whether it's a hospital charge bill, you look at a hospital charge master, some of those are almost impossible for consumers to follow if you can even get the information. So that what you brought up is a huge problem, and we need a way to solve that and get some transparency and get people involved. But this is a very, very difficult area.
And Mark, it's only getting worse, because you've got the situation of the hospitals keep raising their prices, and the other groups keep trying to negotiate bigger discounts from both the managed care companies and the employers and the government, and it seems to be only just exacerbating. And then, of course, employers in their premiums, the cost they're paying, are oftentimes offsetting what Medicare and Medicaid doesn't pay. Well, listen, Mark, we're about out of time. Thank you so much for joining us. If you want to know more about Mark Litow, you can go to pointofview.net. We've got his bio up there and a link to the piece we did for the Wall Street Journal in 2013. So thank you so much, Mark, for joining us.
Thank you for having me.
And we'll be back in just a minute. We've got Hans von Spakovsky here. He's going to be talking about immigration. We've got the president's come out with a new immigration plan. He wants to see if he can get some support for it. Not sure he's going to get a lot of support, but we'll talk about it when we come back. Merrill Matthews coming back with Hans von Spakovsky. So stay with us.
So you sit down and do your budget, and you look at all your monthly costs and your bills and your income, and it seems like there's never quite enough. You know what would really help? Finding $500 a month to help balance things out. That is the typical savings, $500 a month for a family when you switch to MediShare for your health care. And when it comes to healthcare sharing ministries, MediShare is really the gold standard. It's been around for 25 years and has more than 400,000 members. It's been around so long and grown so much because it works. And whether you're single or married or have kids, this could make sitting down to do a monthly budget a lot more fun. $500 a month can more than cover a car payment or pay back loans, whatever. So join MediShare and go out to dinner to celebrate. Here's the number to call. They are incredibly kind and helpful to talk to. 855-90-BIBLE. That's 855-90-BIBLE. 855-90-BIBLE.
Tired of fake news? Support truth. Join Point of View's Truth Team and bring healing to America. Go to pointofview.net/team, pointofview.net/team, or 800-347-5151.
Point of View will continue after this.
I just want to thank you so much for all the wonderful programming you have. You're just absolutely fantastic.
I recently started listening to Point of View, and I really found it interesting because of the different subjects you cover. Thank you for that.
I really appreciate everything that you do in keeping us informed.
Thank you, Kirby, for everything that you have been doing. I appreciate all the work that you're doing, advocating for the Word of God. Thank you so much.
Point of view, I think, is absolutely necessary because it's a Christian perspective, a biblical worldview perspective, and receive very current, up-to-date information about what is really going on, week to week in our culture, which is changing so rapidly, and yet it's morally sliding backwards.
Yeah, I'm just, first of all, I thank you guys. Y'all's program is wonderful, and enjoy it every day. I learn so much every time I listen to it.
Point of View Radio Talk Show.
Hi, this is Kirby Anderson. You know, each day we take on the tough issues and provide a biblical perspective to them. The topics we cover are wide-ranging: apologetics, theology, prophecy, creation and evolution, intelligent design, marriage, family, child-rearing, the millennial generation, trends in society, politics, economics, business, religious liberty, the Constitution, public policy, foreign policy, military policy, tensions in the Middle East, abortion, homosexuality, pornography, sexual ethics, media, technology, history, and America's godly heritage. We talk about anything that affects your faith, your family, or your freedom. So don't go anywhere, because Point of View continues right now.
Across America, live. This is Point of View. And now, your guest host for Point of View.
And welcome to Point of View. This is Merrill Matthews sitting in today for Kirby Anderson. I'm with the Institute for Policy Innovation, and Kirby is out, and I am really looking forward to this hour. We're going to be talking about immigration, at least in the first half hour here. I've got on the line Hans von Spakovsky. Hans is an expert in a number of areas. He is a senior legal fellow at the Heritage Foundation's Edwin Meese Center for Legal and Judicial Studies. He's worked a lot on civil rights issue, voting rights, and also on immigration. He's also co-author with John Fund of the book Who's Counting? How Fraudsters and Bureaucrats Put Your Vote at Risk. Hans, thank you for joining us.
Merrill, it's great to talk to you.
Well, I saw John Fund on Monday in Fort Worth at the Mount Pelerin Society, the regional meeting, so we got a chance to visit a little bit. I've actually got him coming on next week. I'm going to be sitting in again, and we'll be talking about voting rights issues then. So we'll get both sides of your co-authored book on once this week and once next week. So Hans, there was an issue that occurred in Massachusetts here recently, and you wrote about this, and I think it took a lot of us by surprise, where a trial judge decided to take a twice deported illegal immigrant and slip that person out the back door to be able to avoid a custom enforcement agent. Give us the background of this situation.
Sure. This illegal alien was, and there's no question he was an illegal alien, as you said, twice deported. He was actually arrested in Newton, Massachusetts, by the local police for on a narcotics charge, so it had nothing to do with immigration. And when they sent his fingerprints to the national criminal database that the FBI maintains, they discovered that, in fact, he was a illegal alien who'd been twice deported. ICE was notified, ICE over at the Department of Homeland Security, and they sent a arrest and detainer warrant to the Newton police to let them know that DHS wanted to arrest and detain this man the moment the local authorities were finished with him. All of that information, the fact that he was wanted by the federal government, was then sent over to the local court, the local state court, so that everyone there was aware of it. The judge who was in the case, the judge's clerk, in essence, everyone in the courthouse knew that this guy, when he came up, was wanted by the feds. So the illegal alien and his attorney show up in the court before this state court judge. The prosecutor is there, and she decides that she is going to release this illegal alien who's there on a narcotics charge on his own recognizance.
Mm-hmm.
Someone who had twice been deported, and actually there was a fugitive warrant out on him from Pennsylvania, although it's unclear whether this was actually the guy that Pennsylvania wanted. But the point is, ICE knew about this hearing, sent one of their ICE agents as a standard procedure to the courthouse.
Mm-hmm.
He went into the courtroom of this judge, And when the judge found out that an ICE agent was there waiting to pick this guy up, she ordered the ICE agent out of her courtroom. The clerk said to him, well, you can wait in the lobby because that's the way this alien will come out. And then, you go back into the courtroom, and what happens? The judge is reminded by the prosecutor and the lawyer for the alien that there's an ICE agent outside waiting for him after she disposes of the local charge. And she turns to her court clerk and says, turn off the audio recording in the courtroom. Under Massachusetts rules, everything that happens has to be recorded, so you have a record of it. And for a minute, almost a minute, there's silence. And then when they come back on, what happens? She directs her bailiff to get this guy out of the courtroom, the illegal alien. And what do? Well, instead of going out the public door to the courtroom where the ICE agent can pick him up, they take him out a back door of the courtroom, and then the bailiff uses his security card to open up a back exit from the courthouse so this guy won't be arrested. Fortunately for us, the U.S. attorney in Boston, who's a really good guy, a guy named Andrew Lelling, I actually know him. I worked with him at the Department of Justice many years ago. What does he do? He convenes a grand jury, and he indicts the judge and her bailiff for obstruction of justice and conspiracy to obstruct justice, and the bailiff also for lying to the grand jury, because when the bailiff appeared before the grand jury, he claimed he had no idea that there was a detainer, an arrest warrant out on this illegal alien, and had no idea that there was an ICE agent waiting to pick this guy up.
It's amazing because your point is that we think of judges as enforcing the law, and the headline on your piece is judges can't ignore the law. I would argue it's more than ignore the law. She's subverting the law in what she was doing. But how is this playing in Massachusetts? Is the judge getting some support? Or people saying this is I support immigration, but this is outrageous?
No, as a matter of fact, some of the local district attorneys, if you can believe this, by the way, it's not just that she obstructed federal law, but actually the Massachusetts Supreme Court, and this is just a local county court, they've actually issued instructions and rules to all court personnel in the state that they are to cooperate with the Department of Homeland Security and ICE agents. So she violated that directive too. No, she's unfortunately getting not only a lot of sympathy, but several local district attorneys, so these are the county attorneys who prosecute cases, if you can believe it, they've actually filed a federal lawsuit asking a federal judge, to enjoin or stop the federal government from arresting and detaining illegal aliens not only in state courthouses and county courthouses, but any illegal aliens on their way into and out of state and county courthouses.
Oh my. 1-800-351-1212 if you'd like to talk to Hans. 1-800-351-1212. Hans, when we come back and after the break, the president has come out with an immigration reform proposal. Democrats don't seem to be wild about it, but he wants to try to make this a little bit more merit-based on it. And we'd like to get your take on that. Is the president moving in the right direction with this? And does this have a chance of, if not gaining some traction, at least immediately, at some point in the future? Hans von Spakovsky with the Heritage Foundation, and he'll be with us for the next segment. If you want to call, 1-800-351-1212, and you can get a chance to talk to him about what's happening on immigration as the president tries to address some real serious issues that Democrats seem to not be paying much attention to, or even denying them. So stay with us, and we'll be back.
This is Viewpoints with Kirby Anderson.
Sometime in the near future, America will go over the entitlement cliff. That is the argument of Dr. Merrill Matthews, co-author of the book On the Edge, America Faces the Entitlement Cliff. He was on the Point of View radio talk show recently to discuss the problem and possible solutions. The first part of his book explains why entitlement programs fail. To put it simply, they are not actuarially sound. But the problem is even greater than that. He also shows how the cost of entitlement programs always exceeds projections. He details the expansion of Social Security, Medicare, and Medicaid. The second section projects how America will fall off the entitlement cliff. Not only does he provide projections for Social Security, but also for the impending pension crisis, the welfare debacle, and the health care debacle. This is true of both private sector pensions as well as for public sector pensions. He also includes sections on stepping back from the cliff. He deals, for example, with the fact that we have different types of safety nets in society that result in different outcomes. We do have examples in other countries of how to construct a sustainable safety net, and I wish some members of Congress would read the sections on principles of a sustainable safety net and embracing actuarial principles. There are solutions to the financial challenges we face with entitlements, but we also need to elect a Congress, politicians who actually want to solve some of the problems created decades ago with these government programs. So far, most members of Congress, unfortunately, want to ignore the fact that sometime in the future we may go over the entitlement cliff. I'm Kirby Anderson, and that's my point of view.
For a free copy of Kirby's booklet, A Biblical View on Anti-Semitism, go to viewpoints.info/antisemitism. Viewpoints.info/antisemitism.
You're listening to Point of View, your listener-supported source for truth.
Welcome back. Merrill Matthews in for Kirby Anderson. And on the line, we have Hans von Spakovsky. He's with the Heritage Foundation's Edwin Meese Center for Legal and Judicial Studies. So, Hans, we've got the president trying to change the narrative on immigration reform. He made his proposal last week. What do you think about the president's plan?
Oh, I think it has a lot of very positive aspects to it. I mean, just to give you a couple of examples. I mean, the main thing he wants to do with legal immigration is try to cut back on the chain migration we have, which, these days represents about 70% of the legal immigrants coming into the country. And people need to understand, that they're not talking about stopping the immigration of your immediate family members, spouses, your children. But what they're talking about is the kind of chain migration system we have where you can bring in, cousins and in-laws and all these folks. So it's an ever-expanding chain. And what they're talking about is switching to a merit system where we will pick people coming in looking at everything from their fluency in English to their professional and vocational background, experience, and certifications, their academic track records, et cetera. And look, that is a very smart and common sense idea. It's not something somehow unprecedented or nefarious. Canada does that. Germany does that. Australia does that. Countries that a lot of folks, liberals often point to and say, oh, we ought to follow, their policies, particularly places like Canada and Germany. And look, the easy way to understand this is this way. What do you think is going to be more beneficial to the American economy and less of a burden in terms of the government benefits we pay out? A high school dropout who doesn't speak any English, who's coming into the United States because his second cousin is a citizen, or someone fluent in English, a college graduate who has a professional degree as a lawyer or a doctor, or a vocational certification like an electrician. I mean, the answer to that is pretty darn obvious, I think.
So where's the role for those who have few skills and they want to come to be able to do yard work, agricultural work, picking fruit, construction work sometime, and things like that? Where does that role stand?
Well, look, a lot of people often bring up the agricultural area because they say, well, Americans don't want to pick grapes and do things like that. But that's where you can have the kind of guest program that we had in previous years. We had that in the 1950s and early 1960s to take care of that problem. I can tell you that in a lot of other industries, the idea that Americans won't fill that jobs is wildly exaggerated, construction being a good one. I've talked with folks in the construction industry, and I've talked with Americans who say they can't get jobs in the construction industry because too many contractors hire particularly illegal aliens. Because why? Well, they can pay them lower wages, and it won't cost them as much. And in fact, the current system, the most vulnerable Americans are the ones that are hurt by the current system, because the current system undercuts wages and drains our social safety net.
Talk a bit about that program that we had in the 50s. We called it, and I think it was during the war as well. Was it Bracera program? I believe it was. Yeah. And how did that work?
Well, you could, like if you were a farmer and you had a need for a particular number of workers, they could come in on guest visas and would be here for the season when they needed to be picking. But they couldn't apply for citizenship. They had to go back to their native countries when they were done, and that's the kind of guest worker program you can use to fill those kind of slots. Look, the other thing that the president's doing in his plan, and I think this is important, is trying to close some of the current loopholes. And one of them they're talking about, for example, is, as you know, illegal aliens now have been told the way to stay in the U.S. is to immediately claim asylum when you get there, even if you have a totally not a legitimate asylum claim. And what the president is saying is two things. One, you should only be able to ask for asylum if you come in through a legitimate port of entry. If you're sneaking across the border, you should not be able to claim that, which I think makes perfect sense.
Yes.
The other thing that they're saying is, we should have a stand-fast rule that if you're coming into this country, for example, across the Mexican border, and you are from a different country, like you're from Central or South America or elsewhere, and you actually say, yeah, I need asylum because I'm being politically persecuted, if you didn't make that asylum claim the moment you got into Mexico, but in fact you traverse all the way through Mexico and you don't make that asylum claim until you get to the U.S., that's a sure sign you don't have a legitimate asylum claim for political persecution, because in fact Mexico, for example, as does Canada, they have a very broad asylum law, and you can easily, the moment you come across the southern Mexican border, request asylum. But if you don't do that, you come all the way to the U.S., we pretty much know you don't have a legitimate asylum claim. But right now, we have to actually examine and review and investigate that case, and that slows down the system and keeps people in the U.S. when they shouldn't be in the U.S.
What do we do about the visa cases? Because I believe, if I remember right, something like 40% of the people who come here on a visa overstay their visa and don't go back.
Yeah, that's a real problem, and one of the ways that has to be looked at is we need better biometric identifications to be able to keep track of people who come in on those kind of visas. And, part of the issue there could be entering into new relationships with countries around the world that says to them, if the people coming in from your country are visa overstayers and you get above a certain percentage, and there are particular countries where this is really true, if you don't take care of this problem from your end, we're not going to issue visas to allow anyone from your country to come in. And if we did that, for example, I have no doubt that those countries would impose particular conditions on their citizens, students, and others that would basically require them to come back and not overstay in the U.S.
Could we also require them to post a bond so that if they don't show up, that the bond people come looking for them?
Yes, I think that actually is a very legitimate way to review this problem.
Do you, in the couple of minutes we have left, do you think we're going to address this in any major way in the next few years, or is this going to be something that has to wait till after the 2020 election?
It's very clear to me that Democrats are not willing to do anything on this issue. They're not willing to approve anything the president proposes, even on issues where in prior years they actually would have agreed with the president, because they just don't want to give the president any kind of success on the immigration issue. So I'm afraid, other than the president acting when he can through executive action, we are really not going to see any changes in the law. I'd be very surprised.
As much as I hate to say it, I'm afraid you're right on that. Hans von Spakovsky, thank you so much for joining us and discussing the issue of immigration. It's going to be a fight like healthcare and a number of other things we're going to be carrying on for several more years, I'm afraid. Thank you so much for joining us.
Sure, thanks for having me.
That was Hans von Spakovsky. He's with the Heritage Foundation at their Edward Meese Center for Legal and Judicial Studies. So, a number of issues and challenges. If you want, we're going to throw the lines open for the next two segments, 1-800-351-1212, 1-800-351-1212. If you'd like to call and raise some issues about immigration. We're going to be facing that for the next couple of years as we move through this next presidential election cycle, or health care reform, or welfare. We're eager to hear from you. 1-800-351-1212. Call, talk to Steve, let him know what your point is, and we'll try to get you on the air. So we've still got some time to do that. 1-800-351-1212 if you'd like to call. And when we come back, I'll talk a little bit about some of the health care challenges we're facing as we move into this next election cycle and some of the issues they're trying to address. So look forward to hearing you. 1-800-351-1212, and we'll be back in just a minute.
So you sit down and do your budget, and you look at all your monthly costs and your bills and your income, and it seems like there's never quite enough. You know what would really help? Finding $500 a month to help balance things out. That is the typical savings, $500 a month for a family when you switch to MediShare for your health care. And when it comes to healthcare sharing ministries, MediShare is really the gold standard. It's been around for 25 years and has more than 400,000 members. It's been around so long and grown so much because it works. And whether you're single or married or have kids, this could make sitting down to do a monthly budget a lot more fun. $500 a month can more than cover a car payment or pay back loans, whatever. So join MediShare and go out to dinner to celebrate. Here's the number to call. They are incredibly kind and helpful to talk to. 855-90-BIBLE. That's 855-90-BIBLE. 855-90-BIBLE.
Tired of fake news? Support truth. Join Point of View's Truth Team and bring healing to America. Go to pointofview.net/team. Pointofview.net/team. Or 800-347-5151.
Point of View will continue after this. You are listening to Point of View. The opinions expressed on Point of View do not necessarily reflect the views of the management or staff of this station. And now, here again, your guest host for Point of View.
Welcome back. This is Merrill Matthews sitting in for Kirby Anderson. We've been talking about health care and immigration. If you'd like to call and express your point of view, 1-800-351-1212, 1-800-351-1212. If you want to talk about all those Medicare for All proposals that are floating around in Washington right now, or some of the challenges with immigration. And with that, let me go to Dupree in South Carolina. Dupree, you're on the air.
Thank you for taking my call today and listening to my point of view. I want to correct the misconception that illegal aliens are undercutting workers and stealing Americans' jobs. That is not true.
Mm-hmm. That was sort of Hans' position.
Now, that's not true. In our area, the labor pool is so decimated. The only people you can get to work, they want you to pay them in cash because they're on disability, or they failed a drug test and can't get a job anywhere else, or they're on some type of government assistance. And if you can find an illegal alien to do those kind of jobs, they want more money than the H-2A workers that are the guest worker programs. They want more money than that. So they're not stealing jobs, and they're not undercutting them with wages.
You know, it's interesting because I live in a neighborhood in the Dallas area. We have ever since I had my hips replaced back 20 years ago because I had worn out my hips, I've had somebody do the yard. I could do it, but it was a good excuse to start having somebody come mow the yard for me. And a person in the neighborhood does that, and he was talking to me here a little while back about that, and he was telling me all the trouble he has finding workers. You know, he has people come by and do the yard service. And he said he had to, if I remember right, he had to run 2 ads. It cost him $750 to do that. He had to go through several processes to finally get people. And when he got people in, and I think he told me he was paying $10, $11 an hour. I mean, it was well above the minimum wage. And he said it's hard to keep them because construction often is paying much more and is hiring them. So it's interesting because he said he just has fits trying to get people to come do yard work, which typically immigrants coming in through even the legal process, and he goes through the legal process. He pays all the taxes and so forth, but he has trouble getting them in and keeping them, even paying a fairly decent hourly wage.
That's absolutely correct. We got a little small farm down here in South Carolina, and we have a hard time getting people to work. And if you can find an illegal, I mean, you're paying them that $11.50, $12 an hour. You're paying them if they live 20 miles away. You're having to pay them an extra hour a day for transportation, and you're also furnishing them gas. I mean, it's ridiculous. But the other workers, they don't want to work. They want to stay home, and the government's paying them to stay home. There's so many able-bodied people that are on disability now. It's frightening. It really is.
Yeah. Those disability rolls have declined a little bit, but they went up significantly under President Obama, in part because of the recession. Typically, those disability rolls begin to decline fairly soon after the recession's over. The recession's been over since 2009, and we've been in a very strong economy. So, and as you know, we've got a very low unemployment rate out there, and there are employers who are dying to get some workers in. So at least in my mind, we do need to have a legal system that allows people to come here and work, especially in some of the lower income areas. And I don't hear much talk about that. But instead of paying these coyotes who essentially engage in human trafficking $7,000, $8,000, $9,000, I'd rather them pay some kind of entity, whether it's federal government or private organization or something, come be able to do work, go back home. Doesn't mean if you're here and you have a baby, you get to be a citizen. But we need some workers for those segments of the economy.
Yeah, and people got to understand. Every time they sit down and eat, if they eat vegetables of some sort, meat, vegetables, anything, and they look at it, somebody, whether it's has had to labor to make that work. Somebody's had to pick it. Somebody's had to grow it. And This country will never appreciate that till it goes to bed hungry.
I've heard people who in the agriculture area who are saying they can't get the crops in because they can't get the workers, and that just it doesn't ring true to me that it's that we don't have a problem there.
There is a tremendous problem there. It needs to be ready.
Thank you so much for calling, Dupree. And let's go to Whitey in Nevada. Whitey, you're on the air.
Hi.
Hello.
Hello. Which country opens their border for anyone who wants to come in? I mean, you tell me, only America. And don't you forget that when these people are coming in the caravan, do you know what flag they were bearing? They're carrying their own national flag instead of the flag of the United States. It's crazy.
So your point is that we are too open to immigration?
No, we are not too open. We are very open.
We are very okay.
Come on, which country does that?
Well, we certainly have been very open in years past. You know, in our history, we've had times where we're very open, and times where there's been some pushback to that, and said, "Wait a minute, we need to get control of this for a little bit." We've been quite open for a while, and I guess at least the people I talk to, most people I talk to, are very amenable to the notion of legal immigration, where you have people who are able to come here and work. They're registered. We know who you are. We know what you're doing. You can leave and go back and then come back and work and so forth. The illegal immigration has become a big issue, though.
Absolutely, I agree with you. But don't you forget that when they come here, they're bearing their national flag instead of flag of America. What do they come here to contribute towards our economy, or draining our welfare, draining our health care, draining our education?
That's been an issue, because if you come here, arguably they say you don't have the ability to access welfare. You do have the ability to access the education system. If you're here, Supreme Court says you've got to provide education for them. So that happens, but there's this ongoing debate about welfare. But what happens, I think, in a number of cases is a family comes here, they're not eligible for welfare, but then they end up having a baby. The baby born in the U.S. because of the constitutional provision there that is interpreted as if you're born here, you're a citizen. So now they have a citizen. That child is young. The child can't fend for itself and go out and access things. So the child is able to get certain benefits, both health care and welfare. The child can't manage those benefits, so the parents are able to access those. And so you at least indirectly, I think, get an awful lot of people on welfare who aren't necessarily eligible for it, may not even be here legally, but they're managing the children who are here legally.
I agree with you, but we need to change the law.
We do need to change the law. I went to a Federal Society meeting here just last month in Dallas, where they had John Yoo and another professor debating the issue of the anchor babies. Should the Constitution allow somebody who's just born here to be automatically become a citizen? And I listened to arguments on both sides, and it just strikes me that there was never an intention to allow people somebody who walks across the border, has a baby, and then that baby is now a citizen, that there was never an intention to actually to allow that. Parts of the debates from it or so forth were, they discussed the issue, came up, and they said, no, that's not what we want to do. We're not letting anybody who comes in, has a baby, all of a sudden becomes a citizen, and then the other family members become part of that. So it has been a long issue, and we're going to have to deal with that because there's people on both sides of it. But thank you so much, Whitey, for calling. 1-800-351-1212, 1-800-351-1212. For our closing segment, if you have comments about immigration or health care or other issues, I encourage you to call 1-800-351-1212. We spent the first 2 hours talking about the health care issue and the problems that we have facing us right now. My goodness, Medicare for all, those plans are expanding. I think Democrats are going to make that a key provision of their Democratic platform come 2020, I don't think we're at risk of seeing a Medicare for All legislation pass and signed by the president, President Trump. But I do think given who wins the outcome of the election in the November of 2020, we could see a Medicare for All plan being given serious consideration. And if you have a Democratic president at that time, come 2021, you might very well have somebody who's willing to sign that. So if you'd like to comment on health care or immigration, 1-800-351-1212. And when we come back, we'll be glad to take your calls. Let us know what you think about those issues or anything else. It is a swirl of issues out there these days. So we look forward to having you give us a call, 1-800-351-1212. We'll be back.
Now, back to Point of View, your listener-supported source for truth.
Merrill Matthews sitting in today for Kirby Anderson. And for our last segment, if you want to call to talk about health care reform or immigration, the two things we discussed today, or something else, 1-800-351-1212, 1-800-351-1212. And let me just walk through some of the things that you need to know about the Medicare for All plans. I've got about 6 principles here. Number 1, it is not Medicare. Even though they are using Medicare for All, they're using the name Medicare, it is not Medicare. Those of you who are seniors out there, seniors like their Medicare. When they poll seniors, they'll say roughly 75, 80% really like their Medicare. Medicare has some issues, but if you like it, you will not get to keep your Medicare. All the Medicare for All plans, basically the single-payer health care plans, fundamentally change the Medicare program. So if you like it, you don't get to keep it. Tell you something else, you don't get to keep them. This is the number 2 point. Employer-based health insurance. Roughly half of the country gets health insurance through an employer. That's the workers and their dependents. Mark Litow and I talked about that in the last hour, how that came about. But we have an employer-based health insurance system in the U.S. If you like that, and many people do, employer-based health insurance systems typically get employees saying 70, 75, 80% say they like their employer-based health insurance system. You will not get to keep that. Employer-based health insurance goes away. There are many companies out there, in fact, left-leaning people who work for Google, Facebook, some of the major tech companies. Some of them have some of the best health insurance in the world. That goes away under a Medicare for All proposal. So you don't get to keep your employer-based health insurance under something that Bernie Sanders or the House has proposed. Number 3, you must be in the system. You cannot escape it. Under most of these Medicare for All proposals, everybody has to be in the system. You don't have a choice. It's not like that in every single payer system. It is in Canada, but in England, about 10%, a little over 10% of the population is able to opt out. They go out and buy private health insurance out there, and they're able to go see doctors with it and use that private health insurance. They aren't necessarily required to be in the system, but in Canada, you are. Ironically, in the U.S., if you're a senior on Medicare, you have to be in the system. I mean, you must be part of that system. You can't go outside and pay for something outside of Medicare. So you're going to be in the system if they pass the single-payer system. And then there's the cost. The general estimates on Medicare for All, about $3 trillion a year, or $30 trillion over 10 years. It's a huge new expense. They will say, well, yeah, but the employer, the money that we're spending on health insurance now, that goes away. Well, employers are paying the large majority of that because we have an employer-based health insurance system. Unless they do something that requires the employer that essentially taxes that money from the employers may be able to keep that money. So we don't know what happens with that money. Most economists believe that money actually belongs to you because it's considered sort of your compensation package. So instead of paying health insurance, the employer could be providing you with a higher income, but we don't know what happens with that money if we move to a Medicare for All system. It may or may not be taxed by the federal government, but we will be paying higher taxes. Bernie Sanders has been very clear on that. If we move to Medicare for All, your taxes go up. It may be that you see less out-of-pocket cost. We just don't know. But that gets to the very generous benefits that Bernie has been suggesting. Initially, Bernie says he wants everybody to be able to go see a doctor, get whatever they need with no copay, no out-of-pocket cost at all. That does two things. Number one, dramatically increases the cost of his health care plan. But in addition, because people tend to spend more when they're insulated from care, they end up spending a lot more. And so you see healthcare spending go up significantly under that plan. So that's why you have to have a cap on the plan. You have to limit how much is going to be spent on it simply because people are likely to spend a whole lot more. It's just like if you go to a restaurant and somebody else says, Joe, Mary, I'm picking up the tab. Dinner's on me tonight. You aren't nearly as concerned about the cost of the dinner as if you're picking it up yourself. If you go on travel, if you're going on a trip and the employer's paying for that trip, you aren't as concerned about the cost of the hotel or other things as if you're having to pay for that yourself. So you're going to see total spending go up, which is why the government has to step in and try to limit that. they'll put caps on it, and that's where you get the limits on it. And then you cannot pay for things out of pocket. Under Medicare right now, if you go to a doctor, if you're a senior on Medicare and you want to pay for something out of pocket, doctors cannot take that money. You can't pay the difference between what the doctor would charge and what Medicare pays. That's called balance billing. In addition, you can't pay for it out of your own pocket because Medicare prohibits that. So you will not be able, under a Medicare for All system, if you want to go to a doctor outside or you want to pay for something out of pocket, you just simply will not be able to do that. It would be against the law. So it creates a huge new problem for us. Now let's go to the line. We've got Will on the line in California. Will, what's your point of view?
Hey, thanks for taking my call. I was just a little concerned about this new Medi-Cal thing per se, because I paid into the system. I mean, I'm a retired IT person right now, and I paid into the system for about 48 years.
Yes.
And so now they're going to tell me that, that I have to kind of, I got to go by their rules per se. I'm saying, this is the money that I paid into it. I can go back and trace all my paychecks, everything like that, and then I see a lot of people coming through that they're abusing the system. I go, come on now, what about the people who honestly worked and paid into it? So we got to suffer because of everybody else.
Yes, California wants to be on the cutting edge of making sure that everybody gets health care, including, I think the governor has said he wants to include, if he gets to his way, illegal immigrants, anybody being able to go and get the care. And, of course, if you've paid into the system, if you've worked, you've paid taxes, and that goes in to pay for welfare, which is or the Medicaid system, which in California is called Medi-Cal. They've also got subsidies through Obamacare, and then there's the Medicare system, which they're wanting to expand. So, yes, people have been paying in for these things for years, and oftentimes they limit it or control what's happening, or they're opening up the door so that many more people can jump in, and it's going to raise a lot of costs. So, yeah, we're facing that problem. Will, thank you for your call. We're running down towards the end of the show, but Will is exactly pointing out the problem that we're having, especially in some of the blue states that New York is another one that want to be sort of on the cutting edge of being able to say, we are providing care for everyone. New York has stepped up and said, in their system, they're moving to a system. They're going to let anybody access the healthcare system in New York City. It's going to be tremendously expensive. They think it's not, but it will be. Mayor de Blasio has made that point, and now Mayor de Blasio is actually going to run to be President de Blasio. So he wanted to make sure he got in a program to sort of be able to say, I'm doing something about health care. So anyway, we talked today about health care. We talked about immigration, a number of issues. All these are available. A number of articles are available on Point of View's website. So you can go to pointofview.net and take a look at those or the bios of the people we had on today. Enjoyed it. Thank you to Andrew for managing the controls and Steve for managing the phones. And we'll be back tomorrow. Thank you very much.
So you sit down and do your budget, and you look at all your monthly costs and your bills and your income, and it seems like there's never quite enough. You know what would really help? Finding $500 a month to help balance things out. That is the typical savings, $500 a month for a family when you switch to MediShare for your health care. And when it comes to healthcare sharing ministries, MediShare is really the gold standard. It's been around for 25 years and has more than 400,000 members. It's been around so long and grown so much because it works. And whether you're single or married or have kids, this could make sitting down to do a monthly budget a lot more fun. $500 a month can more than cover a car payment or pay back loans, whatever. So join MediShare and go out to dinner to celebrate. Here's the number to call. They are incredibly kind and helpful to talk to. 855-90-BIBLE. That's 855-90-BIBLE. 855-90-BIBLE.
Tired of fake news? Support truth. Join Point of View's Truth Team and bring healing to America. Go to pointofview.net/team. Pointofview.net/team or 800-347-5151. Point of View is produced by Point of View Ministries.